Okay, great. Can we get started? I think we can get started. Great, thanks so much. Really excited to have one of our last What's New in Addiction Medicine talks, if not the last one of the year. Nathan Stefani, one of the Vancouver Island Addiction Medicine Fellows, will give us a really interesting talk on an area that I actually don't know very much about at all, so I'm really looking to learning some myself. So Nathan's a fourth year Emerge resident, and we're very fortunate and blessed to have him as part of our Addiction Medicine Fellowship program here in Vancouver Island. He's chosen to do the Addiction Fellowship in order to gain understanding and expertise to better serve patients who present to the emergency department with substance use issues. He's really passionate about policy changes, culture shifts within the ER that leads to more compassionate and evidence-based addiction care across the island. And so he's working on a couple of very interesting projects right now that are really looking to push forward the interface between addiction medicine and the emergency department. One being a Suboxone microdosing project for people suffering obviously from opioid use disorder, and another one being a gabapentin prescribing for low-risk alcohol withdrawal for people with AUD. So alcohol, opioids, now the thing that kills probably more people, more than any other substance, smoking. So take it away, Nathan. Thanks so much.
Awesome.
Oh, I forgot to say, he also likes bird watching and long walks in nature.
Yeah, now my bio is complete. Thank you. Really great to be here. I think this is the last What's New in Addictions Medicine. It's a privilege to be able to be speaking to you from Edmonton. I'm actually doing an ARCH rotation here at the Addiction Service at the Royal Alex and getting a bit of interprovincial experience, which has been really sweet. Bringing some pearls back to BC soon. So thank you for showing up. Thank you for being here. I'm looking forward to talking to you today about an area of addiction medicine that often isn't as popular to talk about or to learn more about, just because we're inundated with smoking and tobacco use disorder at all times. I think even in our consults, sometimes we forget to even consider it as a substance of note when it's been overshadowed by a lot of other substances often in people's world. But that means that maybe it's time to take a little fresh look at it. And I have a chance to chat to you today about some novel approach that I've learned recently around a smoking cessation adjunct or medication called Cytisine. And let us, without further ado, dive right in. If you have questions, please post them up into the chat or write them down, hang on to them. We can have some time to discuss them after the presentation. All right. I have no disclosures, and I'd like to acknowledge that I usually live and work on the unceded, never surrendered Coast Salish territory of the Lekwungen and Musqueam First Nations. A little outline of where we're going today. We're going to talk about a bit of the background, tobacco use disorder, a historical context, what Cytisine even is, why you maybe have never heard of it, and the evidence for Cytisine in smoking cessation. We'll talk about some dosing, cost effectiveness, and then we'll take it with a summary slide at the end. So to begin, tobacco use disorder. 14.6% of Canadians smoke tobacco, and this number is from a few years ago. Projected is that more and more people are smoking tobacco with also the adjunct of vaping. Nicotine use is continuing to increase. A leading cause of premature death is tobacco, more so than alcohol, more so than opioids, even with our pandemic currently. This is costing Canada healthcare up to $20 billion per year. So this is unprecedented in terms of substance use burden. I know we love that word unprecedented these days, but this really is. So in order to kick their smoking habits, it's interesting to know that about 2 out of 3 smokers actually plan to quit in the next 6 months, if you ask them. and about half of them have tried to quit in the past year. Only 30% of people who end up attempting to quit smoking actually access any medical help in order to quit. And with that, an unaided attempt fails about 95% of the time. So it's interesting to know that quitting is on a lot of people's mind, even if they don't endorse it or even if they don't bring it up in your clinical encounter. But it's also interesting to know that unaided attempts at quitting, such as cold turkey or trying to cut back yourself, that's very difficult to sustain cessation. And so this leads us to thinking about screening and treating for tobacco use disorder as something that is paramount for us as healthcare providers. So what can we do, or how effective is our intervention? Well, some literature shows that a brief intervention by a healthcare provider, and in these studies it was a physician, but pretty much anybody that has expertise and is willing to take some time to talk to their patient about smoking cessation, has a number needed to treat of around 80. This may seem high, but if you take it in context of the number needed to treat to prevent one death, stroke, or heart attack in people with high blood pressure, if you're giving them a blood pressure medication, that's a number needed to treat of 700. Aspirin to prevent an MI in a year, that's over 100. So in the realm of number needed to treat, this is actually quite excellent. If you were to add on a cessation medication on top of your brief motivational interview, this number needed to treat actually goes down even further. So this highlights the importance of both taking time to talk to patients about smoking, then also providing them smoking cessation medications. This leads us to our options, and you are all well aware of the top three. I would believe nicotine replacement, varenicline, and bupropion. Now, you may be less familiar with the fourth one, cytisine. Now, cytisine was also not on my radar at all until I was actually on an inpatient addiction week with Dr. Theo Jankowski here in Victoria. And he, being a very student of the literature and always perusing interesting papers, he brought this up to my attention and asked why I'm not using cytisine for helping people quit smoking. And I had no answer because I'd initially thought, oh, is this like an acetylcysteine? Because we seem to use NAC for a lot of stuff, but no, this is different. And then he pointed out this paper, and this is a nice review paper from the CMAJ that came out in 2018. It highlights smoking cessation with cytisine, and it got me thinking. I'd never heard of this, and so I did some more looking into it and realized that there's a lot of evidence, a lot of momentum that I think it's high time that us in the addiction world learn something about it. So what is cytisine? Well, it's derived from the Cytisus laburnum plant, as you can see on the right-hand side. A beautiful flowering plant that's native to Central and Southern Europe and Eastern Europe. Cytisine itself is an alkaloid derived from the plant leaves, and it's actually a partial agonist at the alpha-4 beta-2 nicotinic acetylcholine receptor, the same receptor that nicotine lands on with its effects on the brain. So instead of a full agonist, it's a partial agonist. It has the same effectiveness, or the same, it has the same mode of action as varenicline, binding to that same receptor. And interestingly, back in the day, there's anecdotes of World War II soldiers strapped for access to cigarettes, actually chewing on Cytisus to ease their cravings. And maybe they were onto something. And it turns out that cytisine has actually been used for smoking cessation in Central and Eastern Europe since the 1960s. So it is well established. If you were to be a Bulgarian or a German or Polish, you very well likely have heard of cytisine and maybe have tried it in your attempts to quit smoking. Cytisine properties. So it does, like I said, act on the central nicotinic receptors as a partial agonist. Its time to peak concentration after an oral ingestion is about 2 hours. It is eliminated by the kidneys, almost 100%. So there's no hepatic metabolism, which is good to know in regards to drug-drug interactions or influencing hepatic metabolism of other drugs. There is none. So in that respect, it is a very quote-unquote clean medication without a lot of other interactions. It has a shorter half-life than varenicline at 5 hours versus 17 hours, and a full treatment course, evidence-based treatment course of cytisine is only 3.5 weeks rather than 12 weeks with varenicline. So already we're starting to see, well, cytisine as a really interesting and viable alternative to varenicline or other medications that might be helpful for smoking. This is just to highlight the fact that nicotine and cytisine and varenicline all bind to the same receptor, but the smaller the K value or the affinity to that receptor, the higher the affinity. So cytisine and varenicline actually have a higher affinity for that special focus than nicotine does, which means that they bind more tightly. They're able to offset the nicotine and decrease the nicotine's effects at that receptor, decreasing the amount of reward that's related to the amount of dopamine release that's related to somebody taking a cigarette and using the nicotine. So it helps to offset the withdrawal. It does provide some agonism at the receptor, but it also unhinges the reward pathway related to the nicotine use. And that's how varenicline works. It's well established, and it's how cytisine works as well. So why have you never heard of cytisine? Well, this might have something to do with it. I don't know if you were perusing the literature in 1956 in a very interesting German paper, Therapiewoche, but you would have come across this paper and would have found that actually cytisine might be very helpful. Or this one, which has been translated from a Bulgarian journal. Essentially, all the original studies of cytisine were done for smoking cessation in non-English journals. And that might be why we in the English-speaking Western world have not heard of it yet. Also, the fact that it has a generic structure. So it's naturally occurring, and it just makes market exclusivity very difficult to obtain. And because of a low selling price, given this genericness of it, no drug company has really had much incentive to popularize it. That being said, there is one drug company now that has started to make it and produce it, manufacture it and distribute. So in the Western world. But that might be part and parcel to why you haven't heard of cytisine before. And maybe you have, maybe you're on the clean edge, but this was news to me. So, well, why has it become more popular for us, and why has it reached the CMAJ just a couple years ago? Well, in 2006, there was a big review, literature review and meta-analysis by Mr. Etter, and he published this, basically consolidating all of the information from these non-English speaking journals, non-English journals, and did this meta-analysis of all the literature, English and non-English, to then come forward with this conclusion that cytisine has evidence for effectiveness in smoking cessation. So that was back in 2006. At the same time, the same year, varenicline was approved for use as a smoking cessation agent. So there was evidence relating to cytisine, and then the sister compound, varenicline, was now suddenly available. So that made people more interested in sort of a partial nicotine receptor agonist for therapy. And I think that also led to people wondering whether cytisine was maybe also helpful because of its natural occurringness, its genericness, it's cheap, and it would be amazing if it actually worked. So, well, what is the evidence for cytisine? So let's walk through this a little bit. A first main paper relating to cytisine's effectiveness in smoking cessation was from Hajek et al. In 2013. And this is a large meta-analysis of over 4,000 adult smokers. It actually reported a 59% higher abstinence rate among cytisine users than those using nothing or using a placebo. And so that's encouraging. So cytisine is better than nothing. And the number needed to treat was around 6, which is quite amazing. So that established its baseline effectiveness compared to placebo. The next paper a year later from Natalie Walker et al. She's a big researcher out of New Zealand, I believe, and you'll see her name on a number of papers coming out relating to cytisine. But she initiated this open randomized trial that showed self-reported abstinence rates higher in the cytisine group versus the nicotine replacement therapy alone group. And this was both evidenced at 1 month as well as 6 months. And you can see the percentage of abstinence, unsurprisingly, is higher at that 1 month mark and less so at the 6 month mark, but still statistically significantly higher in the cytisine group than NRT, with very impressive NNTs. The caveat to this paper is that a lot of these people had already tried and failed NRT in the past. And it's also difficult to blind whether between nicotine replacement and cytisine, just because cytisine is a tab and it's quite a regular regimen of multiple pills a day versus NRT, which is hard to conceal, hard to blind. So obviously methodologically not perfect, but still showing a signal that there might be something to this cytisine. So side effects and the cautions that came out of these two first papers were that cytisine is associated with some dyspepsia, some nausea, sleep disturbances, but all these were self-limited, and only about 5% of people actually stopped using cytisine due to these side effects. And in terms of contraindications, they're essentially the same as varenicline, being its sister compound. So people with severe hypertension, atherosclerosis, pregnancy or breastfeeding, it's advised against cytisine. So this draws us to a critical juncture of trying to decide, well, what about cytisine versus varenicline? Both of these have similar actions pharmacodynamically. What is their relative efficacy? So when I was first looking through the literature, this is the main paper that I found around basically a theoretical comparison of cytisine versus varenicline. So there's a large systematic review of over 10,000 patients, combining as many studies as possible. I looked at varenicline or cytisine. And at the time, in 2014, there was no head-to-head trials. And so as you can see, there's a large preponderance of evidence for varenicline versus cytisine, but they did their best to include the major papers for both. And their conclusions, and I did not delve in deeply and appraise the actual paper itself, but they said that cytisine is anticipated to dominate varenicline with more quality adjusted life years at a lower associated cost. And so they were doing their best to compare using models, and it sounds like about 90% of the scenarios that were performed came out with cytisine being the superior option to varenicline. Similar in their effectiveness, but the fact that there's lower costs associated made it a better option. And so this is all theoretical. There's no head-to-head trial. And as I was looking, I came across a very recently published online, not yet in print, paper that starts to answer this big question. And this is Natalie Walker, once again, coming up with this first paper that's actually comparing varenicline to cytisine. So this is exciting stuff. So this was looking at varenicline in New Zealand Indigenous Maori people. This was a randomized controlled trial. So it was designed as a non-inferiority trial, cytisine versus varenicline, and they looked at a significant number of Maori or extended family members of those of Maori heritage, randomized to 12 weeks of either cytisine or varenicline. And if you can remember, the 12 weeks of cytisine is more than what has been typically established. But regardless, they were comparing as best they could equal between the two. Self-reported abstinence at 6 months shows the following: 12% abstinent in the cytisine group versus around 8% in the varenicline group at 6 months. So even at baseline, both these medications seem to be quite effective in helping at 6 months. And it's comparable to the other trial that we saw of abstinence rates at 6 months. However, there was found to be significantly more side effects with the varenicline group relating to GI upset, sleep disturbances, vivid dreams, those sorts of things. And the cytisine group did not have as many of the side effects. So the bottom line that the authors conclude is that cytisine isn't as effective as varenicline with less side effects. So well, what do you know? This is all just fresh off the press, March 2021. So this question obviously begs to be answered further. There's a study ongoing that they've published their protocol, and it's still collecting or processing the data, but basically assessing the effectiveness, safety, and cost effectiveness of cytisine versus varenicline, again, down under. So this is one of Dr. Walker's contemporaries. So we'll see what this shows. I wasn't able to find any other big studies going on at this point, but this study is going to have over 1,000 patients randomized. So hopefully this will provide a bit more evidence. But in the world of addiction literature, where we deal often with such small numbers in our studies, it's really encouraging and exciting to have a paper that is randomized, controlled as best as possible, and showing non-inferiority between cytisine and varenicline. So where does this leave us? So cytisine as a potential alternative to the other medications we know and love for smoking cessation. Well, how available is cytisine? So back in 2017, cytisine was approved by Health Canada as a natural health product, which means that it's purchasable from select pharmacies, from health shops, and actually directly from the manufacturer, Z Farm. So this is the bottle. The product is called Crave, and it can be delivered to your doorstep with a few easy clicks. There's no prescription necessary, which makes it even more accessible to a lot of people. So cytisine dosing, the typical regimen lasts, as you can see here, 3.5 weeks. So the capsules that you get in one of those bottles, the Crave bottles, they each have 1.5 milligrams of cytisine in them. And the first few days, you're taking a capsule every 2 hours. The peak effect reaches, as we said before, in about 2 hours. So you basically can perpetually dosing yourself with this medication to cover the receptors. And the idea is that in the first couple of days of your regimen, you're going to be slowing down the amount that you're smoking. And by day 5, you essentially are encouraged to quit. And for many people, anecdotally, they don't really need cigarettes past day 5. So it's quite cool. And days then 4 to 25, you're on this basically a tapering regimen of the cytisine tablets. You extend out period bit by bit, until by the end of day 25, you're using 1 or 2 capsules, and then you have completed a course. So cytisine is also not just effective, as we've established, but it is cost effective. And so here are some numbers if you don't believe me. So nicotine replacement therapy, not covered by Quit Now BC. So if you were to try go beyond that 3 months of coverage and try to quit again in a year, you're going to be, or your healthcare coverage is going to be paying about $300 to $400 for a course of treatment. And bupropion or Zyban is over $200. And these are conservative estimates from about 3 or 4 years ago. So I wouldn't be surprised if these medication costs were higher. Varenicline is about $340. Cytisine, a full 25-day course, $69. And I looked at that yesterday. So with shipping, only $79. So it just makes the point that cytisine is cost effective comparatively to the other options that are out there. So I was wondering to know if I was the only one that had never heard of it, and it kind of sounds like I am, because I went on to Quit Now BC, and the most updated webpage does endorse cytisine as an option. So it talks about the medications requiring prescriptions, talks about quitting cold turkey, and then it has cytisine as the next tab down. So that's exciting. The word is getting out. And it actually has a really nice, simple description of what cytisine does, presents some of the evidence of it being potentially superior to NRT and on par with varenicline. And then it, however, being a health product is not covered by med plans at this time. And so that might be a barrier for people that aren't able to pay $69 for a medication. But in comparison to how much cigarettes cost for 3.5 weeks, patients can do the math and make that decision for themselves. So ex-smokers review Cytisine as well. And I mean, this is unbiased from the Z-Pharm website itself, but there's pages and pages of these actually, and it's interesting to see people providing their anecdotal support for how Cytisine has helped them quit. The Z-Pharm is a Canadian company, and it's Cytisine is manufactured, the Crave product is manufactured in Canada as well, if that's of concern or importance to you. So this brings us to our summary slide. Cytisine is a cost-effective and non-inferior option to varenicline, with fewer side effects and a shorter treatment course. It's also cheaper. Cytisine is superior to nicotine replacement therapy alone, as borne out in the literature that we have. And finally, that's something to consider for your next patient who is wanting to quit smoking. And interestingly enough, what was underlying Dr. Walker's efforts around Cytisine is because, at least in New Zealand and in Australia, there's quite a skepticism and a hesitancy to engage in westernized medicine for a lot of people that are of Aboriginal and Indigenous descent. So they were trying to come up with more of a natural remedy that people might be more open to. And so I haven't delved further into the paper, but they did make mention that the reason why it was so successful for a lot of Maori people in particular was because it was a natural occurring product. And so this is also something to have in the back of your mind if you're coming across somebody who is interested in quitting smoking, yet is reticent to engage in maybe more of a westernized, medicalized approach. Cytisine could be a very cool option for them. So those are my references, and I really appreciate your time and your attention. I'm happy to take any questions.
Awesome. Thanks for that presentation, Nathan. Really great. We'll just wait a minute or two for any presentations or any questions, sorry. I have one or two that I can think of, but we'll just see if anyone has any others. So the idea for this presentation came from just you connecting with Theo during a rotation on addiction on AMCS. Is that? So he came across it.
I don't really know how he came across it, other than he's Theo and he seems to be appraised of all the most recent literature. But he had asked me if I'd ever heard of Cytisine, and I said no. And he's like, well, there's this paper that had mentioned that it could be quite helpful, and so that was my first foray into it. And looking further and deeper, it actually was surprising that this is what's new in addictions medicine for us, but it is actually old and has been used for multiple decades with evidently huge success in Eastern Europe, which is just fascinating to me that there can be this huge disconnect even in what's available or what people find helpful when there's a language barrier or a language or a publication barrier, essentially, of how none of these papers ever made it to the West until 2006. So what else is there that we don't know about? That's my question.
Yeah, for sure. To me, it also really speaks to just, if there's a drug company that's going to make a lot of money on it, then it's going to be promoted, right? And this, great that this Z-Pharm is making it now, but it wasn't available before, or hard to be available. I guess also there's a lot of people who only want to use natural products, and so they're worried about medication. But then there's also the other side of people who are like, oh, if it's not a prescription, if it's just a natural product, it probably whatever, maybe doesn't work. So there's people on both sides. So it's good to have lots of options, I think, is the bottom line.
I mean, that's why I'm also glad that it's getting some credence even among, like, in Quit Now BC, which is something that I refer people in the Emerge to quite often and say, hey, this is, if you're interested, this is your next step. Quit Now BC, it's online and it can help connect you to people to support you in this next, this important step to getting off smoking. And then if they're, to scroll down just beyond the varenicline NRT, and then Cytisine's right there. And so looking at the BC CSU guidelines, cytisine doesn't make any appearance whatsoever. And so it's just interesting to see that, already there's some movement and of introducing this, and I'd be fascinated to see how this continues to grow, the momentum for it as time goes on.
Yeah, for sure. So one of the things you mentioned, you're interested in policy. And I've wanted to try and start a more robust smoking cessation clinic in Victoria for a while, and just hasn't made it to the top of the to-do list yet. But sort of thinking about if we would try and advocate for cytisine to be available, it's cheaper and it works better than NRT, right? Like that, what's the reason not to use it? And obviously, inertia, and we have NRT for free in the hospital, NRT for free in the detox, lots of places, obviously 3 months you can just get it for free from a pharmacy. So if you would think of what do you think the lowest hanging fruit would be to try and incorporate cytisine somewhere in our addiction care system, either in addition to NRT or even replacing NRT? Sorry to put you on the spot. I'm not a softball question kind of guy.
The low-hanging fruit. I think it would be, whoever is going to be in charge of establishing a clinic like this, and it would obviously be lots of stakeholders that would want to have something to do with it, but essentially presenting the money. I think the financial aspects of establishing anything like this really are the bottom line. And so kind of coming at it from that perspective of talking to those who might be providing support and funding for it to say, hey, there's a more cost-effective option than nicotine replacement therapy. What do you think about making a big mass order from Z Farm and having it available instead of NRT? Which is, obviously there might be conflicts of interest perceived there, but if it comes down to the money aspect, then that is something that's hard to argue with. And I think people, when they look at the cost effectiveness, that's really what makes policies change, is if you can prove efficacy, but also saving money. I'd be interested to see how much money, put in a dollar figure, how much money you'd save if you had rolled out cytisine rather than NRT, or some combination thereof.
Right.
Yeah, it'd be fascinating. I mean, it would be interesting to see what the production even is, or whether this is, because I haven't contacted Z Farm and I don't know what what level of output they're doing, because I don't think cytisine is really available anywhere in this context or to this capacity. It's just being ordered online by individuals. So, yeah.
You probably don't know. Is it in health food stores in Victoria, or?
I didn't have a chance to go and peruse, but I did do some Googling, and in select London Drugs, I believe you can get it, and you can't get it on Amazon for somehow the supply is, I just couldn't buy it from Amazon, but I can order directly from the manufacturer.
Z Farm.
Yeah.
Okay, I see there's one question. I'm not sure if there's others that I can't see, but it says you referenced NAC early in the presentation. Can you confirm if there's any similarity in the way these two compounds work? It sounds like no, just similar names between cysteine and cytisine.
Yeah. I did a organic chemistry degree that was 9 years ago, and so really rusty on this, but I know it's cytisine is an alkaloid. And N-acetylcysteine is essentially an amino acid, so they have very different chemical structures, and they act on very different things. So I believe it's more to do with the connection of just a similar name than any similar activity in the body.
Yeah, gotcha.
Yeah, but who knows? Maybe N-acetylcysteine, if we give it enough time, might come out as a helpful next adjunct to smoking cessation as well. I mean, we consider it with maybe smoking marijuana, but not yet tobacco.
Yeah, the cytisine NAC double whammy for people who mix tobacco and cannabis.
Yeah.
Okay, well, I don't see, I'm not sure if there's other questions. It's a bit hard for me to be sure if I'm seeing all the questions or not. I don't know if Adrina or Ramin wants to confirm that there are no other questions that I can see.
Yeah, there are no other questions.
No other questions? Okay, great. Well, then thank you very much. Awesome presentation. Definitely an area that we should all consider in whatever policy areas we have to try and get it more on people's radars, for sure. So thanks a lot, Nathan.
Yeah, and if anybody has wants access to the slides or my references, which kind of go through all the papers, then by all means, please contact me. I didn't put my name there. It's just nathanstefani@hotmail.com. So pretty simple. Happy to take your questions afterwards and to give you any information I can.
Amazing.
Thanks, guys.
Thanks so much. Okay.
I'm looking forward to being home, Ron.
Sounds good. Take care. Awesome. Bring lots of pearls back.
Yes.